Well, it's an absolute thrill to be presenting at the first annual North Carolina or Carolinas MPN Summit. And the topic that I was assigned is talking about ruxolitinib, the good, the bad, the suboptimal, and the failures, which obviously is a riff on the good, the bad, and the ugly, the classic Western movie. And so, kind of taking that in mind as a framework, the good is to me quite obvious. Ruxolitinib changed the face of the care of patients with MPN. It injected interest, it injected funds, it injected research, it propelled the field forward in almost immeasurable ways. It makes patients' spleens better. It makes their symptoms better. People live longer who are on a JAK inhibitor than versus those who do not. It's optimized patients for transplant. The list goes on and on and on. So the good is the easy part. The bad really is the cytopenias and the side effects, namely cytopenias, because when anemia and thrombocytopenia occur in the face of ruxolitinib treatment, we have to back off the dose. And by backing off the dose, we see less efficacy with spleen and symptom response. And then the ugly is what happens after ruxolitinib is no longer benefiting that patient. Survivals are predicted to be very short. Those are often associated with molecularly advanced disease, and those patients should really be considering clinical trials or transplantation at that point. And so in a nutshell, that's kind of the presentation, is laying the groundwork there for where we are with ruxolitinib today. So we can start looking forward, looking at newer therapies with JAK inhibitors, combinations, and the like.